So thank you very much, everyone, for your interest and attendance this afternoon and this evening, wherever you are in the world. Today it gives me great pleasure to introduce two of my close colleagues, Dr. Noreen Akhtar and Dr. Guy Betts. Guy has been a consultant pathologist at Manchester University Hospital, where I'm based, for nearly 10 years, and he's been a head and neck pathologist here for many years before that, having started in surgical training, doing a PhD in head and neck oral pathology, and then moving into pathology training. So I've known Guy for probably close on 20 years, I would say. Excellent colleague, very, very helpful. I used to do head and neck in the day. When Guy and his team came along, I very graciously gave it up. So thank you. Also introduce Dr. Noreen Akhtar, been in the trust for about 5 years now, a key member of a very busy head and neck team. We're a kind of tertiary referral centre for the City of Greater Manchester and beyond. Very grateful for their continuing involvement in many teaching activities I shamelessly request of them. So without taking any more time, I will pass over to them. So over to you two. Thank you very much.
So hello everyone, it's a great pleasure to be here and thank you very much for inviting us, Richard. I'm just going to share my screen. Great. So can everybody see the presentation screen? I think given that we're
yes,
on
I can see it fine.
Thanks very much, Richard. So I think there's a Q&A or a chat box. So if you do have any questions, then please put questions in the chat. So what we're going to do today is I'm going to talk for probably about half an hour about some head and neck pathology, mainly about oral and head and neck squamous cell carcinoma and a bit of oral pathology. And after that, then my colleague Noreen is going to present a couple of cases from the last few weeks that we found interesting, and I hope that you do too. So I've got nothing to declare in terms of any financial interests. So head and neck pathology is quite a diverse area. It shows a lot of overlap with other specialist pathology areas, including skin pathology, soft tissue pathology, lymphoid pathology. But there are also some areas that are unique to head and neck. So particularly salivary gland disease, which I think you had a talk on last week, but also sinonasal disease, some odontogenic pathology, and infectious and inflammatory diseases. So this is a case of an elderly patient. This is a few years ago now, during the COVID pandemic, who presented with rhinorrhea and some nasal pain. And he had been treated with steroids for COVID. And in this sample, we can see we've got some nice sinonasal mucosa with underlying bits of bone. And then on higher magnification, there's some inflammation centered on the blood vessels. And then when we look with some fungal stains, we can see these broad hyphae situated within vessels, which show up very clearly on the Paz stain and a bit on the Grocott stain. Paz obviously works a bit better for mucor in these situations, but this is an example of a patient with invasive fungal sinusitis with broad hyphae within vessels and was likely related to steroid treatment for COVID. So this just highlights the importance of infectious pathology in the head and neck region. So during this presentation, we're going to talk a bit about squamous cell carcinoma, about limitations of pathology. But one thing I really want to emphasize in head and neck, as with all pathology areas, is the importance of the correlation of pathology with clinical findings. And in fact, this is often the most useful pathological device you can use, as putting some of these specimens that we see in the correct clinical context by talking to the surgeons or some of the specialist nurses is really vital to getting the correct diagnosis. So head and neck squamous cell carcinoma. So we're very familiar with head and neck squamous cell carcinoma. It can occur anywhere in the head and neck, any mucosal site, and the etiology varies a bit by subsite. I think we're all familiar with the risk factors of alcohol and tobacco smoking, which in combination lead to a 40-fold increase in risk of squamous cell carcinoma in combination. Also important to note the use of areca and betel nut use, which can be associated with oral submucous fibrosis and is also associated with a high risk of progression to squamous cell carcinoma. Human papillomavirus is becoming increasingly important in some areas of the world, and genetics. An important point to note here is that second primary malignancies, for example, head and neck, lung, or esophagus, are the leading long-term cause of mortality in patients presenting with HPV-negative head and neck squamous cell carcinoma. So that means that if patients are, one thing we can do when we see these patients is try and stop them from being exposed or continuing to be exposed to any potential carcinogens. So there is a role for encouraging patients to stop their alcohol consumption, stop tobacco smoking or betel nut use in order to prevent them from getting second primary malignant tumors. This is, I was playing around on this website, the Global Cancer Observatory website. I think it's French, run by the WHO, where you can look at incidence and mortality of different cancer types across different subsites and across different countries and regions of the world. So I've pulled out age standardized incidence and mortality. So incidence in blue and mortality in red, and the x-axes are the same in each of the graphs across different subsites of the head and neck. It's quite interesting seeing the different regions of the world reflected for the different subsites. So for hyperpharyngeal cancer, we have a higher incidence in South Central Asia, maybe a bit in Western Europe, and South Central Asia as well. There's a very high incidence mortality for lip and oral cavity cancer, probably due to potentially betel nut use. Also high up here, we have Australia and New Zealand, probably through sun exposure and lip cancers. On the bottom part of this graph, we have a high incidence of nasopharyngeal cancer in Southeast Asia and Micronesia due to its association with EBV. And then for oropharyngeal cancer, we have highest instances in Western and Northern Europe, Australia and New Zealand, likely due to HPV-related cancer. So I'd encourage you to have a look at that website and just play around and see what the prevalence and changes in incidence of cancer in different subsites in different parts of the world are. So this is an example of a squamous cell carcinoma. I think we're all very familiar with these irregular nests of very atypical cells with mitotic figures and dyskeratosis. This is another example of a squamous cell carcinoma, looking a bit more poorly differentiated here with surrounding inflammation. This is another squamous cell carcinoma. Apologies for the out of focus photograph. Here we've got more broader cohesive nests of tumor. And this is another squamous cell carcinoma. And here the tumor is more basaloid with these large areas of geographic necrosis. So the point I'm trying to make here is that head and neck squamous cell carcinoma is morphologically and molecularly very variable. This picture on the right of the screen is a figure from a paper from 2018 where they genetically sequenced the genome of about 10,000 tumors and tried to cluster them. So you can see that some of these clusters are quite tight. For example, this little pink dot here for diffuse large B-cell lymphoma is all the tumors are clustered quite closely together, or for glioblastoma down here, again, the tumors are quite closely clustered together. But for head and neck squamous cell carcinoma on the right upper area, the dots are all over the place, which just indicates the molecular heterogeneity of these tumors. There's no specific molecular targets in head and neck cancer, but it may be that this molecular heterogeneity makes the immune tumor reaction a bit more important, and that might open up some treatment avenues for these patients. So head and neck specimens, from the macro point of view, these are often complex, involving bone and quite convoluted mucosa. So when you're dissecting these, always pay attention to the location of the tumor in order to work out closest margins, and think about potentially surrounding dysplasia, as if there is severe dysplasia going to these floor of mouth margins, then that's an indication that we'll need to pay attention to when we come to post-op follow-up or even further treatment for the patient. In this case, you can see I've removed the bone from the tumor, from the patient specimen. It's also equally valid to keep the bone intact and to decalcify the entire specimen and section it with the bone in place. Labeling and orientation of specimens is very useful. This is an example of how we are spoilt in our institution, that we receive specimens pinned out on the board with often the levels of the neck dissection clearly labeled and often the margins on the main specimen clearly labeled up as well, though there's a deliberate mistake here in that the left and the right are the wrong way around. And this is an example of the tumor after we've cut it, so we can see that ulcer on the floor of mouth region with an underlying pale tumor infiltrating into the skeletal muscle. So that's clearly over 10 millimeters depth of invasion, and that's a big tumor. So this is probably a T4 anterior floor of mouth tumor. So prognostic features in primary head and neck squamous cell carcinoma. So main indications post-operative radiotherapy or chemotherapy, extranodal extension of tumor in lymph nodes and positive resection margins. But we also consider other factors. It's important. So close margins, large tumor size, presence of nodes, perineural invasion, non-cohesive pattern of invasion. These are all factors that we're quite familiar with as head and neck pathologists as being poor prognostic indicators. Other potential prognostic features, tumor infiltrating lymphocytes are prognostic in HPV positive and HPV negative head and neck cancer, but as yet there's no accepted criteria for scoring or role for these really in treatment decision making post-operatively. PD-L1 status, we are increasingly using immunotherapy now for recurrent head and neck squamous cell carcinoma with patients with positive PD-L1 status, and potentially the role of cancer-associated fibroblasts if we develop some drugs that specifically target cancer-associated fibroblasts. That may be another future area of treatment. Risk scoring, so people listening to this may be familiar with work of Margot Bramwell-Gensler in the States, who came up with this risk scoring based on a combination of what she called worst pattern of invasion in combination with the lymphocytic host response and presence of perineural invasion. This risk score correlates very well with TNM staging and outcomes. And the worst pattern of invasion 5 on a score of 1 to 5 is defined as tumor nests over 1 millimeter apart within the stroma. And this is becoming more widely used as it adds additional information to the existing criteria of cohesive and non-cohesive invasive front and is a bit more objective. Here's an example of worst pattern of invasion 5, where we have an infiltrative tumor in the top left-hand corner of the screen and a small nest of tumor in the bottom right, over 1 millimeter from the main tumor, that counts as worst pattern of invasion 5. And this does indicate that we have such a thing as bad biological behavior of cancer that can be indicative of a poor prognosis, even in potentially small-sized tumors. Another prognostic factor is nodal disease, and particularly the presence of extranodal extension or extracapsular spread of tumor. And this chart here was developed over 20 years ago now by a pathologist, Julia Wilgar, who was based not too far from where I'm sitting now. So she was based in Liverpool, we're in Manchester, and showed that patients with extracapsular spread in their lymph nodes had a much worse outcome than those with lymph node positive disease but without extracapsular spread. There's now more evidence that the distance of extracapsular spread may also be prognostic, and that minimal extracapsular spread of tumor, i.e. less than 1 millimeter potentially, may reduce the need for chemotherapy in oropharyngeal cancer. So we're starting now to record the extent of extracapsular spread as well as its presence or absence. So we often, well, we don't get resections initially. We usually have to diagnose these tumors on biopsies, and sometimes that can be challenging. Most of the time it's straightforward. But in some cases, we receive quite small samples, particularly at sites such as the larynx, In our institution, we're getting increasingly patients having transnasal biopsies without general anaesthetic, which result in quite small biopsies of often superficial samples, which can cause problems. Superficial samples is also particularly need to consider in subtypes where you can have deep tumours. This is particularly true in the tongue base or in patients who have recurrent squamous cell carcinoma, where the recurrence may occur deep to the mucosal surface. So always bear that in mind when reporting a normal or inflamed superficial sample where there's a high clinical suspicion of cancer. Poor orientation, presence of inflammation can be difficult, and lack of adjacent normal mucosa. So some pitfalls about diagnosing squamous cell carcinoma, or some mimics. So dysplasia going into salivary gland ducts can mimic invasive squamous cell carcinoma. If we do have dysplasia going into ducts, it's usually has a very cohesive outline, and we can usually make out the duct in other sections. If you have dysplasia going to salivary gland ducts, that means this is high-grade epithelial dysplasia. Pseudoepitheliomatous hyperplasia can be difficult, as can necrotizing xylometaplasia. Odontogenic rests are important to bear in mind, particularly the juxtaoral organ of Chivitz, which is present in the retromolar area in the oral cavity. So this is a biopsy of a laryngeal tumor. We can see it's quite superficial. We've got a lot of keratin debris with very little underlying stroma to identify invasion, but we can see that we've got quite significant epithelial atypia, got abnormal keratinization. I think in some of the sections there was some increased mitotic activity. So we can make a diagnosis on these samples, and then we can correlate that with the clinical impression and with radiological images. Usually we say this is highly suspicious of squamous cell carcinoma, and we're not sure if it's severe dysplasia or cancer. And you go along to the MDT and they show the CT scan of the larynx, and there's a really massive tumor there invading into the thyroid cartilage with lots of cartilage destruction. And there's no doubt over the diagnosis. Necrotizing xylometaplasia can be challenging. This site is usually on the palate. These nests are rounded, and the important point here is that the nests preserve this lobular architecture that's recapitulating the residual salivary gland that has been inflamed and is now showing severe squamous metaplasia. So look for adjacent atrophic inflamed minor salivary glands, and look for this preserved lobular architecture and the lack of cytological atypia. Now, these can show keratinization, but they're well-rounded nests without infiltration within this lobular architecture of the salivary gland. Pseudoepitheliomatous hyperplasia, again, could be challenging, but this also lacks cytological atypia. Usually these nests are rounded, but they can appear infiltrative. In this image, we have pseudoepitheliomatous hyperplasia occurring as a reaction to an underlying granular cell tumor. So do always look in the underlying stroma, but you can get similar features in relation to trauma or candidiasis. Precursor lesions are quite common. They show variable degrees of cytological and architectural atypia, and interpretation and diagnosis of these is based on a combination of cytological and architectural features. There are various grading systems around. We use a mild, moderate, and severe epithelial dysplasia grading system, and the risk of progression between these lesions varies, but is generally low. For severe epithelial dysplasia, I think it's only in the order of 20 to 30%. Candidiasis, again, is quite common. Here we have an example on the left-hand side showing these squared off hyperplastic rete processes, a kind of sericiform type pattern with surface keratin and occasional neutrophils seen within the surface keratin. You can get some basal atypia and maybe occasional suprabasal mitotic activity, but that is all related to the candida, which we can identify on a PAS diastase stain. We often use PAS diastase as these are quite hard to see with the naked eye, and even for only very occasional candidal hyphae are significant. It's difficult to gauge dysplasia and risk of progression in inflamed lesions, particularly if there's candidiasis present. But our reports may well indicate in an inflammatory lesion the need for follow-up, possibly after antifungal therapy, to ensure that the lesion resolves and exclude underlying dysplasia. But the best clues for dysplasia in the context of inflammation would be look for areas that are uninflamed and see if the atypia or dysplasia persists in those uninflamed areas or away from the area of ulceration or inflammation. Are inflammatory lesions premalignant? So the WHO recognizes oral lichen planus as at risk of malignant change, but the degree of risk in these situations is controversial. There was a paper came out last year in Journal of Clinical Oncology that did show a high incidence of pre-existing inflammatory tongue conditions in patients that were diagnosed with oral tongue cancer, which would seem to support a role of preceding oral inflammatory lesions as being at risk of progression. How to distinguish between an inflammatory lesion with reactive type atypia and oral dysplasia with an associated inflammatory reaction? We often can't is the answer to that, and don't try to do things that are impossible. So often we need to communicate with our clinical colleagues and explain to them the fact that there is some atypia here. It's probably indeterminate for low-grade epithelial dysplasia, and please follow the patient up. This is an example of a patient with oral lichen planus. So this is a fairly typical appearance, a fairly atrophic appearing squamous epithelium with an underlying dense lymphohistiocytic inflammatory reaction with lots of lymphocyte exocytosis and basal cell damage and some focal little apoptotic bodies. In some situations, you can see cleft formation at the level of the basement membrane due to basement membrane weakening by inflammation. That's not to be confused with pemphigoid. So pemphigoid can also present with a kind of desquamative gingivitis type picture, which oral lichen planus can also show. And here we've got quite clear clefting at the level of the basement membrane. But this does not show the lymphocyte exocytosis that we see with oral lichen planus, and doesn't show the same dense inflammation or band-like inflammation underneath, although it is usually associated with some mild lymphoplasmacytic inflammation. On the right here, we can see the linear basement membrane positivity for IgG and C3c on immunofluorescence. If there's concern in a biopsy about whether some basal cell clefting could be due to vesicular bullous disease or oral lichen planus, then sometimes put a comment in about asking the clinician to check if the clinical presentation is potentially concerning for vesicular bullous disease. In that case, they could consider additional serum testing or sampling for direct immunofluorescence. Pemphigus, on the other hand, shows a different pattern of morphology with clefting within the epithelium due to epithelial acantholysis. This often occurs in older patients where the antibodies are attacking the desmosomes between the keratinocytes, and that immunoglobulin deposition can show up again on immunofluorescence where we see this kind of basket weave type interkeratinocyte positivity for IgG and C3c. It often presents with these kind of erosive oral lesions that you can see in the central image. So to talk about verrucous lesions as well, verrucous lesions are challenging. Proliferative verrucous leukoplakia is a condition that can affect older women. It's not that common, presents with gradually progressive and often multiple lesions with a high rate of recurrence following excision and a very high rate of malignant transformation. So lots of gradually progressive hyperkeratotic white lesions in the oral cavity. Histologically, these can show an inflammatory reaction in the early stages, which can look a lot like oral lichen planus. And again, I can't emphasize this point enough, can I, today, that clinical correlation is really important for diagnosis. So both in terms of how these lesions behave over time, but also in the presence of multiple lesions. Management's often very difficult, involving surveillance and expectant biopsy resection when needed. So this is an example of an early lesion of proliferative verrucous leukoplakia with thick surface orthokeratosis and a lichenoid type inflammatory reaction underneath. Then with time, the surface keratosis becomes more verrucous, and then you start to develop increasing architectural complexity with these endophytic, quite deeply pushing rete processes showing bridging and an associated, continuing associated inflammatory action. And then with time, you get these very broad pushing rete processes, again with the surface very verrucous papillomatous architecture. Then these deep rete processes become broader and more endophytic and maybe a little bit more atypical around the base, but generally these lesions are very well differentiated with minimal cytological atypia. Verrucous carcinoma can arise from proliferative verrucous leukoplakia. It can arise independently of proliferative verrucous leukoplakia as well, commonly in the buccal mucosal region. It's important to note, as this has a very low rate of metastasis. In fact, it's a pretty much non-metastasizing squamous cell carcinoma. It's defined as a carcinoma because the nests of broad, well-differentiated epithelium extend deeply into the stroma, up to or into skeletal muscle, and certainly below the level of the background normal mucosa, hence its definition as a carcinoma and its gradually progressive clinical behavior. Invasion or identification of invasion diagnosis can be very difficult on a biopsy if we don't have the adjacent background epithelium. And again, clinical correlation is important to make sure that we don't misdiagnose these as hyperkeratosis just on small superficial biopsies if we don't have the deep aspect of the lesion. So this is an example of a verrucous carcinoma, very well differentiated with minimal atypia and these very broad pushing rete processes extending deep into the stroma up to underlying skeletal muscle. Lesions of proliferative verrucous leukoplakia can also progress to conventional high-grade dysplasia, as we can see in the image on the left here, and also to conventional invasive squamous cell carcinoma. We can see these invasive nests in the image on the right. It's important, therefore, when we get a case of kind of verrucous hyperplasia or verrucous carcinoma, that we look around to see if there is evidence of conventional invasive squamous cell carcinoma showing severe cytological atypia and evidence of stromal invasion. And if that's the case, then this should be called a conventional squamous cell carcinoma rather than a verrucous lesion. To talk a little bit about HPV, HPV-related cancers are mainly in the oropharynx, and we're seeing very high instances of oropharyngeal cancer in some parts of the world due to this infection. So much so that it's led to changes in TNM staging for oropharyngeal squamous cell carcinoma. This is the typical morphology of an HPV-related oropharyngeal cancer. It's almost indistinguishable from the background tonsil, but we can just about make out these nests of fairly bland appearing basiloid cells with central areas of keratin deposition or even necrosis in some areas. These have a fairly typical morphology, but you can also get keratinizing HPV positive squamous cell carcinomas. They usually show block P16 positivity in over 70% of the tumor. There's no obvious precursor lesions identified, and they have a good response to treatment irrespective of whether that's surgery or radiotherapy. Testing for HPV, the American College of Pathologists have brought out fairly good guidance on this that's quite useful. So we use P16 in our institution, as we have a fairly high instance of HPV-related oropharyngeal carcinoma, and P16 immunohistochemistry is enough. In subsites outside of the oropharynx or in geographical areas where there's a low instance of HPV positive oropharyngeal cancer, then the American College also recommend to do HPV specific testing either in the form of DNA or RNA-ish or by sending samples for HPV genotyping. So we send samples particularly from sinonasal cancers when we're worried about HPV related tumors or even laryngeal cancers for HPV genotyping PCR testing, and I've found that particularly to be quite useful. We've had a recent case for HPV positive laryngeal verrucous squamous cell carcinoma. The HPV testing was helpful in making the diagnosis. So other variants of squamous cell carcinoma, we talked a bit about verrucous carcinoma. Spindle cell carcinoma we'll come on to in a minute. Adenosquamous carcinoma is a very aggressive form of squamous cell carcinoma where we have admixed glandular and squamous malignant components, so both components are malignant. We talked about basaloid squamous cell carcinoma, so this picture at the lower right is of a basaloid squamous cell carcinoma with lots of necrosis, often occurring in the larynx, and these tumors are very aggressive with a very poor prognosis. In the top right-hand corner here, we have an example of a carcinoma caniculatum, which is like a verrucous carcinoma. It shows these very burrowing nests, like a kind of rabbit's warren, a very well differentiated squamous epithelium. This can be, again, quite difficult to diagnose on superficial biopsies. We've had some examples of this cancer where we've had to ask the surgeon to go back and take a deeper sample of the tumor in order for us to identify invasion. And then they've sent us a sample including the underlying mandible with clear evidence of tumor invasion into bone, which helped to make the diagnosis, but it just illustrates how hard this could be to diagnose just on superficial biopsies alone. To talk a bit about spindle cell squamous cell carcinoma, these often present as polypoid laryngeal tumors with pleomorphic atypical nuclei and frequent mitoses, often helpful features. Immunohistochemistry is often not helpful, although P63 and P40 may be useful. Cytokeratins are usually negative, and the best diagnostic feature for these is the presence of surface epithelial dysplasia. And the prognosis of these, despite the spindle cell nature of the lesion, is the same stage for stage as for conventional squamous cell carcinoma. So this is an example of a spindle cell squamous cell carcinoma from the larynx. Got a polypoid lesion with numerous spindle cells, which when we look on higher magnification, we can see these show atypical hyperchromatic nuclei. They're quite irregular architecture. This is another example of a spindle cell squamous cell carcinoma. It's a bit more obvious here. We've got the very cellular spindle cell stroma. And on the surface here, we can see we've got this severely dysplastic surface epithelium. Then on immunohistochemistry with cytokeratins this time, we can see very occasional atypical cells budding off the epithelium and extending into the stroma and merging with this cellular spindle cell lesion. Sometimes P63 can be helpful if we identify occasional cells that retain their P63 positivity, and Ki67 for identifying the proliferation within the atypical spindle cells as well. So that's the end of my presentation about squamous cell carcinoma and oral squamoid lesions. So hopefully I've highlighted some areas of diagnostic difficulty on some small biopsies, and once again state the importance of clinical and radiological correlation, particularly when reporting small biopsies or verrucous lesions in these areas, and our ability to use changes over time, particularly in inflammatory or low-grade dysplastic lesions. So thank you very much. I'm now going to hand over to my colleague, Dr. Akhtar, who's going to run through a couple of cases. Thanks very much. So if I stop sharing this.
Hi everyone, I'm Noreen. I'm going to show you two cases which we recently had in past few weeks. I'm going to share my screen now. So can you see my screen?
Yeah, that's great, Noreen.
Yeah.
Yeah.
So we've got two cases. So the first one, I think for both cases, we wanted to share this experience with you in terms of, again, as Guy's been stressing, that it's very important to share with the clinical findings and imaging findings. So I think these two cases very nicely illustrate the importance of these correlation. So this one is a parotid core, and from the low power, if I zoom out, you can see that this pretty much is a fibroconnective tissue, and most of it is a tumor. If I go closer, you can see it's a malignant neoplasm with mostly very large round to polygonal cells. It has good amount of cytoplasm, which is very eosinophilic, and these odd eosinophilic globules. The significance of at that time when we were interpreting we couldn't understand. And then if you see the nuclei, most of them are very well-rounded and large, and are vesicular nuclei with a very prominent nucleolus. So I mean, based on that, and it's a parotid core, generally, whenever you have a malignant neoplasm from the side, you'd start to think about the primaries from, and then we were wondering in terms of a differential diagnosis of a very poorly differentiated carcinoma, and obviously some possibilities of some metastatic possibilities. In terms of the primary, we because it had a very eosinophilic cytoplasm and a vesicular nuclei, slivy duct was in the top differential diagnosis. Then maybe a squamoid component of a high-grade mucoepidermoid component. The other things to consider, could it be an adenocarcinoma NOS? And then if it is not a carcinoma, could it be a melanoma, which can have all sorts of morphological sort of spectrum melanoma? And then since the metastatic disease, is it a squamous cell carcinoma or something else? The odd thing in the morphology was during initial sort of screening was that these nests and sort of trabeculae, they were arranged in these nests and trabeculae, and I could see that most of these were lined by these endothelial cells. And I'll come back to this feature, and I'll show you the next sort of so that's the other core, which shows again very similar morphological features. So in terms of, say, you're thinking between a carcinoma and melanoma, so the main stain which all you're aware of would help you is a cytokeratin. So in that case, sorry, it takes a while because internet's been slow today, sort of. So this is the cytokeratin stain, which is positive in this case. One can argue you can still have an aberrant expression of cytokeratin melanoma, and we have seen that. And we did a wider panel of immunohistochemical markers. In this case, S100, SOX10, HMB45, and Melane were negative, so melanoma was excluded. Now, the squamous cell markers, they were also negative, P40 and P63. And then androgen, which was done for the slivy duct carcinomas, were also negative. I still, because of this feature I described just now of the end, I wondered about whether this could be a hepatocellular carcinoma because of this very distinctive trabecular arrangement and this lining of endothelial cells. Again, if you can see here, this nested pattern, and I think there are few, I can't find now, but I did see some SNR formation as well. For that, we did do markers. This is cytokeratin, and this was the HEPAR1, which wasn't really very strongly positive, and there were just few cells, if scattered here and there, which showed cytoplasmic positivity, although it was positive in like strongly positive in the cells where it was positive, but mostly it was negative. And then the other stain I did was, which I got back quite late, was arginase 1, and that was negative as well. The rest of the markers in the context of metastatic disease are not really useful, but I still did AFP, which is quite strongly positive, but we know that AFP can be positive in hepatocellular carcinomas, in polydifferentiated adenocarcinomas, and in your germ cell tumors as well. So we were sort of still in a fix, and parotid being a sort of a very rare site, we were not sure that based on a focal, just HepAR1 positivity, should we be able to diagnose that this is a metastatic hepatocellular carcinoma. So basically what we did, as we said, got in touch with our radiologist and asked them that if they saw anything in imaging which could help us. And they found a huge liver mass, which they thought was a primary, and this patient had a widespread disease, metastasis all over the body, including this Mets, which is eventually we found out was not a parotid core, was this deposit was next to parotid in the masseter muscle. So this is a case of a metastatic hepatocellular carcinoma, where again, I think the morphological features, if you notice them, are quite useful. And as shown you, the IHC was not very helpful, but I think the correlation was quite useful in the end. So this was the first case. We can take the questions, or if you want to, if anybody wants to ask anything right now, or shall I move on to the next case?
I think it's okay to
Yeah.
move on to the next case, please. Thank you.
Yeah. So the next case is another interesting we found it very interesting because so this was sent as this is again an 8-year-old male patient, and this was sent as a nasal tumor. So you can see that there are multiple fragments. A lot of them ulcerated. This is an ulcerated mucosa, and where it is intact, you have squamous epithelial lining. And even from a low power, this you can see that this is a tumor, and which is very blue appearing, and then you have you can say this is a round blue cell tumor. So before I go to the nuclei, I would like you to um, sort of go through a mental list of the round blue cell tumor in the nasal cavity. If I can share, uh, just give me a second. Yeah. Can you see this table? So this is a nice article where they've given a sort of a table of all the possible entities of all the small round blue cell tumors. So melanoma, rhabdomyosarcoma, sinonasal undifferentiated carcinoma, and now we have had from them a lot of entities which have sort of, the INA1 carcinomas and SMARC A4 undifferentiated carcinoma, nut carcinoma, neuroendocrine carcinoma slash small cell carcinoma, lymphomas, olfactory neuroblastoma, Ewing sarcoma, and a pituitary adenoma. And so this is your list of all the round blue cell tumors. And obviously, you do have some histological features which can be useful. And we'll go back to our case. So if we if in all it's all quite monotonous appearing. Um, and then we don't see any squamous differentiation, but then we've had many examples of nut carcinomas and sometimes basaloid squamous cell carcinomas where you don't see squamous differentiation, and in the end you have to rely on your squamous cell IHC. The other differential, if you look at the nuclei closely, I think they are very sort of salt and pepper, and there's a very scant cytoplasm. So the other top differential would be neuroendocrine carcinoma, and also small cell variant of melanoma, which again can be um, uh, can have, as I just said, that melanomas can have a wide morphological spectrum, so they can be also they can also have a similar appearance. So if sort of having this list of differential diagnoses, I'll show you the mm, sorry, because so this was cytokeratin positive tumor, and it was negative for all the melanoma markers. I'm trying to actually, and this is a synaptophysin stain. So you can see the tumor is very strong, diffuse synaptophysin positive. Synaptophysin, I'll just stop and mention that synaptophysin can be positive in alveolar rhabdomyosarcomas as well. So you should have another neuroendocrine marker. Again, this is the chromogranin. Again, you can see it's very strong, diffuse positive. And the Ki-67 in this case was around 90%. So looking at the list I just showed you, and because it's CK positive, so it excludes the possibility of olfactory neuroblastoma, plus S100 was also negative. There were no sustentacular cells. So uh, I think our main differential diagnosis would be a high-grade neuroendocrine carcinoma, most likely a small cell carcinoma. Now, the only odd thing in this case was, and I'm not saying that you don't see, you can see very similar morphological pattern in small cell carcinoma, was very less. I mean, there was sort of less molding, but I've seen similar small cell carcinomas as well, and they were nicely respecting each of the boundaries. But this is again, it's just a subtle feature not mentioned in the books. So I did some additional panel, and whilst we were waiting for those, this case was listed in the MDT. And while we were discussing the case, when they showed the imaging findings, this tumor was in the interior part of the nasal cavity, and it was very close to the vestibulum. And because I had requested the other markers, which I'll come to, I just asked the clinicians and the radiologists that could this be arising from the skin of the nasal vestibule? And they all took a while and they said, yes, it could be arising from the skin. And I did say that I was thinking of a Merkel cell carcinoma as a differential diagnosis. So I would wait for the markers, and the next day when we did get our markers, which is a CK20. So this is the dot positivity for the CK20, which is quite diagnostic. So this was, and the other marker which I haven't scanned in is STAT-B2, is also quite useful, which was also strong nuclear positivity. So this was a Merkel cell carcinoma. So again, the importance of clinical and imaging correlation. I mean, I've shown you the list and all the articles you will read about the small round blue cells from the sinonasal tract, because it was just sent as a nasal cavity, a nasal tumor, and the exact site wasn't mentioned. You would not consider Merkel cell carcinoma as one of the differential diagnoses, but because this was a bit interior and was going internally into the nasal cavity, it just shows that this the correlation should be done with your imaging findings and with the clinical findings. So yeah, that's me. Thank you. I'll stop sharing my screen.
Thank you very much, Noreen, for those really instructive cases. It just shows that, you know, lesions from all over the body can present in the head and neck. So head and neck pathologists really have got to be very wide versed in their pathology knowledge. It's unusual getting a hepatocellular carcinoma traveling all the way to that area, but you know, nothing is impossible. In terms of, and also I was interested to hear about the case where you know, the superficial lesion, you weren't able to comment whether it was invasive or not, and yet on further, exaggeration almost, the specimen went all the way down to the mandible. So in that second case, Guy, was was it clinically suspected that it was that deep, or that was a surprise to people?
Um, I think it was clinically suspected that it was malignant. I don't think they clinically suspected it was actually invading into bone. Um,
Okay.
but yeah, clinically they thought it was going quite deep, but we obviously didn't get that in the initial sample, or
Yeah.
due to poor, orientation of the specimen, the very well differentiated nature of the epithelium in carcinoma caniculatum. It's very difficult to identify invasion.
Okay. So I suppose a real learning point is that in any of these kind of like verrucous lesions, it's really important to get a deep biopsy, and a superficial biopsy is not adequate. Is that correct?
Yeah, absolutely. Yeah, I completely agree with that. And
Yeah.
discussion with the clinical team to put things in context, particularly to knowing the exact subsite of the lesion and the clinical history as well. I mean, that's particularly
Yeah.
true in cases of things like pseudoepitheliomatous hyperplasia. We had
Yeah.
one patient with nests of very well differentiated squamous epithelium within the stroma that was in a site adjacent to a recent resection for squamous cell carcinoma on the palate. And it was only after, and some of these nests were close to nerves, so quite deep down within the stroma. But it was only on discussion with the clinical team we discovered that the patient had been repeatedly suctioned in this area for retained secretions in the post-operative period, and it was that trauma that had led to the pseudoepitheliomatous hyperplasia that we were seeing, and it wasn't malignancy, which was we were able to then reassure them that what we were seeing wasn't cancer. So the
Okay.
clinical correlation is vital. Yeah.
Yeah. Thank you. Are there any questions or comments from the audience at all? Nothing so far. So we've got a question here. What from Mary Mungania? What's the best way to decal the large mandible without interfering with tumor characteristics, including invasive components?
Shall I answer that?
Yeah, yeah,
So
please.
the main problem with decalcification is that it renders the tissue unviable for any further molecular characterization. We tend to decalcify our specimens in 15% formic acid. It usually takes a while to decalcify them. So if we bandsaw the specimen first and then decalcify it, it'll probably take about a week to 10 days. But if we're decalcifying the specimen whole, it can take several weeks before we're able to cut the specimen. Using 15% formic acid, we don't find any degradation in the kind of morphology that we're seeing. And the specimen's usually fairly straightforward to cut. But after decalcification, we're not able to um, use the tissue for any molecular testing. And the alternative in the specimens that I showed during the talk is to remove the soft tissue from the bone, and then you can cut up and process the soft tissue as normal and just decalcify the bony sections to look for bony invasion at a later date.
Okay, thank you very
Hope that
much.
helps. Yeah.
Yeah. Any other questions? Yep, they agreed.
Thanks, Mary.
Thank you. Are there any other questions? No? Well, I think you've presented really good cases. Thank you, and a really good talk. Very clearly presented by both of you and easy to follow. And it will be available to all the people. They'll get it emailed out to them, and it'll be available on the Diagnexia site. So I think, in the interest of time, given everyone's busy schedule, I can stop there if that's okay with yourselves, Guy and Noreen.
Yeah.
Thank you
Yeah,
very
thank you so
much.
much.
Yeah, yeah.
Thanks very much,
Uh,
Richard.
so next week it'll be Heme Path once again. So same time, same place on Wednesday. Look forward to seeing you all again. So in the meantime, Thank you very much also, Ava, for your continued support of the programme. And good night, good evening, and good morning for different parts of the world where people are joining from. Thank you.
Thank you.
Thank you. Bye now.
Bye.
Thank